Okay. Good afternoon. What about others?
Good afternoon, Miss.
Okay.
I think maybe they are not free.
Okay, so please, it's possible to send a message that please that the class is going to be started. Because now I don't have mobile with me. That's why. Please.
Allow you to do your exercises and restore function, do a normal walking pattern and the ankle. Okay, so first thing I want to go through with you first is using crutches. Okay, whenever you're out of your cast. So a normal walk. Pattern is getting the heel down first, and then lift the weight down through the leg, and then rolling off onto the toe. So head straight, foot flat, and then rolling off onto the toe.
Okay, so let's get started.
Okay, Miss.
Okay. Have you sent the message? Okay, so we all have seen for each and every fracture, we have different protocols, right? So the location and the type of surgery or the pathology and other comorbidities, everything will play a major role in progressing the rehabilitation. Maybe old age people, we cannot be that rapid rehabilitation cannot be achieved. So slow, steady, and gentle way you have to progress. And maybe adults and healthy and fit, maybe sports people, this kind of population, you can go for some kind of little bit faster compared to other groups. So for patellar fracture, right? Patellar fracture. We already completed the mobilization, rehabilitation, or do we have to start? Supracondylar. Yesterday, where we stopped? Wait a minute.
Miss, I think yesterday we stopped until treatment, if I'm not mistaken.
For supracondylar or patellar? Which one?
Supracondylar.
Oh, okay. Thank you. So this is one of the common fractures. This one has when you start the rehabilitation for week 1, when you take week 1, here also the same, like most of the fractures, you need to avoid passive movements. So next thing is, so this is a precaution. Actually, we have precaution for passive. Don't ever attempt passive things. And then you can allow to do active range of motion, active ranges, and also attempt full extension. And full extension and 60 degrees of flexion. You can allow it like full extension and 60 degrees of flexion to the knee. Okay, that is gentle, and whatever it is, some people it is safe that up to 60 degrees you can go for, but some people are not that like they cannot tolerate the pain and all, so allow them. Whatever is available, you can go for. Maybe 30 degrees of flexion means just allow it. Whatever the range they have, you can allow it up to 60 degrees. And then no strengthening exercises, no isometrics, nothing. And non-weight bearing, purely non-weight bearing, and use for mobility, for bedside mobility, you can use the pivot transfers, stand and pivot transfers, and weight bearing also strictly no. Okay, so yesterday we have for every fracture rehabilitation, we have come across this term called the pivot transfer. We all know that, but if you're not that well versed in that, we can see what is pivot transfers. Can you see this? Can you see the video? Stand pivot.
Yes, Miss.
Okay.
Hi, my name is Scott Holster. I'm a physical therapist at Carolina's Healthcare System, Carolina's Neuromuscular ALS and MBA Center. This video is on how to complete assisted stand pivot transfers. First, notice the wheelchair is set at a 90-degree angle. So it's nice and close, so the person's not having to step far back into the chair. Next, having the person almost start to return a little that, so they're not having to take an extra step or swing or pivot over. With foot placement, helping them slide their foot forward. That way, this is closer to where the left foot's going to wind up versus leaving it back here and they're not able to move their foot during the transfer. It can place extra pressure.
But the one thing for this type of thing, it's actually for ALS, but now we are using it for non-weight bearing. So ask them to don't put weight on the affected side.
On the knee, pulling their back foot underneath them will just allow them, again, to help use this leg to stand. We're going to count, that way the person will know when you're going to complete the transfer and they're able to assist as much as they can. Reach underneath the person's arms. That way, if they're able to, they can use their arms to assist with the transfer to help them push up. So you want to put your hands down here to help you lift up. We're going to stand up on a count of 3. And then you're going to lean forward as you stand. 1, 2, 3. Coming up all the way. Good. And now we're going to shift and slide that foot back. And we're going to have the seat. And just making an effort to keep your back straight and bending with your bending your knees and using your legs to do the lift will help ensure success. And that's how to complete a stand pivot transfer.
So to make them stand also, you can use the same way. Okay, but along with that, you can use crutches or walkers. Okay, whatever it's walkers maybe for elderly group and crutches for adults and fit person. So these are the ambulation, the functional activities and bed mobility. You can go for this type of pivot transfers and non-weight bearing, purely non-weight bearing in the first week. And then in the second week also, you can the same, avoid passive range of motion, and you can allow active ranges and attempt full extension. Full extension, it's safe to do. And up to 60 degrees of flexion, knee flexion, it's you can freely do. And then strength training, here you can do isometrics, that is in the supine lying. You can start doing gentle, mild isometric exercises, and supine and knee in full exercise, like how we do, right? The towel roll under the knee and ask them to press it. And other than that, the non-weight bearing and everything is same. Non-weight bearing for functional activities, as well as you cannot go for the affected side to be bearing weight. And after that, from 4 to 8 weeks, you have here also till 8 weeks, avoid passive range of motion and greater than 90 degrees. Now we can allow more than 90 degrees. And then in this stage, if fracture is stable, means you can assist. Okay, so active assistive range of motion in flexion and extension. Okay, so just mild assistance can be provided. And strength, the isometrics to quadriceps and hamstring can be started. And one more thing is, other than that, no weight bearing. Okay. So for supracondylar fractures, they said up to 3 months. Up to 3 months, you cannot bear weight. Okay, that is very important. Specifically for this type of supracondylar fractures, we have this. Once again, 1 minute.
Miss, may I ask something?
Yeah, sure.
Why lower limb fracture usually takes longer time to heal than the upper limb?
Maybe the weight bearing and the composition, the stronger one. So it takes longer time to heal. Everything is bigger bone, right? And activity level also. Mostly you can see that the stability is the primary factor in lower limb, right? The weight bearing, one of the essential thing for lower limb is weight bearing. That's why it takes longer time to, because it's harder compared to upper limb, because it's used to what is the use of that limb, that way it becomes, right? So upper limb we don't have, like it is not primarily used for weight bearing. We are using upper limb for mobility, right? The movements, majority of the work movements, and very rarely we are using for weight bearing. Okay, so it's not that it's equal importance can be given for upper limb mobility and stability, but lower limb, when you take it, its primary role is weight bearing. So it becomes stronger and more hard compared to upper limb. That's why any break in that structure can take longer time compared to upper limb. Okay, so that is the main
Okay,
reason.
Miss. Thank you, Miss.
No problem. You have to restrict like supracondylar fracture. Please be careful with 3 months. We need to be non-weight bearing for 3 months. So it takes a year. It becomes milestones or long period. They used to have that depression or so many things. We are just we are talking in our view, right? But when you in view of patients, if you think about the 3 months of bedridden or non-weight bearing, it's not bedridden, actually non-weight bearing thing is really it's too painful. They may depressed, or sometimes some people they can't because no one to take care of them, so many problems. So sometimes they use their limbs, and it may delay the healing also, like that. It's a long process. So always remember, for 3 months, they are not allowed to bear weight. And one more thing is, we can here, these are all standard protocols. You can adjust it. You can, according to some healing stage, rate of healing, and then the stability of the fracture site, everything will, maybe you can adjust it. You can fasten up the rehabilitation process, or sometimes you can delay it. Maybe 8th week, you have to start this active range of motion greater than 90 degrees. But some people, all are not same, right? Some people cannot go for maybe they don't show improvements what we expected. So that time you have to be very gradual. Don't push them or don't create pressure. Just ask them to do, and give instruction to caregivers about the consistency, the routines. They need to develop routines of doing exercises, active exercise. And you can go for gluteals, gluteal isometrics also you can start. So, and one more thing is, here the walking is 2-point gait. 2-point gait means one is walker, another one is non-affected side. Okay, so as a first point is, you have to move the limb, move the walker or move the crutch as a one, and then next step is the unaffected side should move forward. This is a 2-point gait or non-weight bearing gait. After that, 12 to 16 weeks, you can no aggressive passive range, but you can start the passive ranges, but it won't be that stressful. And then both active and passive ranges. And here the quadriceps The quadriceps, the last degrees are mostly lost in this fracture because 3 months, take for example, 3 months of non-weight bearing and it becomes weak. We call it extension lag. The last 10 degrees of knee extension, they cannot achieve. So you have to concentrate on that part, the terminal extension. So just to give importance to the terminal extension. And then that is the VMO. The main thing is the vastus medialis oblique is responsible for that. And then you can give a strength training for isometrics, isotonic and isokinetic exercise also. The velocity constant exercise, and then the movement, while resistance, they need to move the jaw limb. So isometric, isotonic and isokinetic exercises to quadriceps and hamstring, and start gentle PRE. Gentle means very basic one, maybe lower than 10 RM. Like that, you can start the progressive resisted exercise. And so strengthening the quadriceps, and because the muscle weakness should be corrected. And now we can come to partial weight bearing, only partial weight bearing with the crutches or walkers, and then the progress to full weight bearing. Okay. So if it is like sometimes the progression, partial weight bearing is painful, means started with toe touch. Toe touch means whatever the toe touch can bear weight, that thing you can allow, and then go for partial 50% of weight to the affected side, and then the progress to full weight bearing. Maybe if it is difficult for them or too painful, we can go with this. Okay. So this is for supracondylar fractures. So for each and every stage, the assessment is also very important. Assessment like, is there any numbness, any sensory loss, any motor, like muscle weakness or muscle paralysis, and any capillary problems, anything you need to check each and alignment also. Alignment of the fracture site, and is there any angular deformity, and is there any wound, the infection at the wound site. So everything should be checked throughout our rehabilitation. We need to be careful with that. And one more thing is the knee varus and valgum. Is there any deformities? Sometimes it heals wrongly, that it looks genu valgum or varum. That is also you need to correct it. Okay, so now we are moving to patellar fractures. Okay, so if this is totally actually different. You can start weight bearing from week 1 itself. You can start bearing weight, because why we are safe means it's a non-displaced fracture. Because of that, this fracture is more safe and less complicated compared to other types. Why we are not we are allowing weight bearing means the patella is not a weight bearing joint, right? So that is a one reason, because the most of your body weight is transferred through tibiofemoral, not patellofemoral, right? So only for mobility we have patella. So for week 1, when you take that, avoid passive range. For this thing also, don't use passive movements. Okay, and range of motion. Is if it is covered in a cast and all, like conservative management means range of motion is you cannot do. But if it is like open reduction and internal fixation is achieved, means we can start active range of motion. Okay, so active ranges, knee flexion and extension can be started in sitting. Okay, not weight bearing, sitting position. And no strengthening exercise. Here, opposite. You don't start any strengthening exercises because of the isometrics to quadriceps and hamstrings may get more influenced. That muscle contraction can cause change in the patellar position. So no strengthening exercises and full weight bearing during transverse and ambulation. Okay, full weight bearing can be it's possible. Using assistive device itself, we can use full weight bearing. And during casting and all, check for the abnormal friction. Maybe sometimes this POP or the cast can cause rubbing or friction to that skin surface. So we need to check that also. And the pain, is there any numbness or all the things, the capillary refilling, everything need to be checked. And if swelling is there, means allow them for elevation. Pillow arrangement is such a way that it's lifted, the foot end is lifted. And week 2, here also same, most of the things are same like first week. And week 4 to 8. So here the precautions, what are the precautions means if tenderness is there in the fracture side, if still the tenderness is present, means you can use knee mobilizers. Okay, so 1 second. Sorry, knee immobilizers, not knee mobilizers, knee immobilizers. Okay, so maintain knee immobilizers if tenderness is present, means ask them to wear it during sleep, or if they are not doing exercises, they need to use this knee immobilizers. And other than that, you can allow active range of motion, and from this week you can start isometric exercises to quadriceps and hamstrings. And 1 minute. Okay, so if it is 4 o'clock, after 4 o'clock, we will meet it in we will use other ID. Okay, so I already told you, maybe the 2 to 3 time, 3 to 4 time, many of them don't know, I think that is the reason. Or but it's in group, right? It's shared already.
Yes, miss.
Okay, just remind me that we'll need to change our IDs. Okay, for after 4 we have to use some other IDs. Okay.
Okay, miss.
So, oh my God. So isometrics can be started. Quadriceps and hamstrings. And one more thing is at 6th week, after 6 weeks, you can start isotonic exercise also. That is TheraBand, pulleys, or like that. The mild version of isotonic exercise to quadriceps can be started, and but the range is like 45 degree to 0 degree. Okay, after that you cannot return back. Okay, so resistance can be for only 0 degree, 45 degree to 0. Then from 90 degree, if you are going for 90 degree, then 90 to 0 degree. That is, you can manage it for one way, for full extension only. After that, this returning phase, you don't apply isotonic exercises. And other than that, you can start full weight bearing. And if fracture is stable, means remove the immobilizer. For level ground walking, if fracture is stable, means we can remove it. And after that, 8 to 12 weeks, passive range, you can start active. Already we have started active ranges. The passive range can be started, and the main complaint is the knee extends us. It may be weak, or it produces pain, and that problem would be there. And so the extension lag, that last 0 degrees, the full complete extension, we need to struggle for that. And then this quadriceps weakness and immobilization cause this problem. So always concentrate on quadriceps. So you can start PRE to quadriceps and hamstring with weights. And if needed, you can, if it's available, we can start isokinetic exercise also using any advanced Cybex isokinetic dynamometer. You can use that. And that is everything is fixed. We can fix the speed, and it's a type of passive movement, but the speed is designed according to that. You have to move your limb. And plyometrics, also jumping closed chain exercises, can also be started. So now this is the period where we are starting the closed chain exercises. That is squatting and this kind of things, mini squats. So the tibial fractures, the tibial plateau fractures. This is also have we completed this? No, right?
Not yet, Miss.
So I think we have come across this classification, so that we have different classification for that. The important thing is this Schweitzer classification of tibial plateau fractures. It's divided into 6 types. That is purely splitting of the lateral tibial. Most common is lateral aspect, the lateral tibial condyle. And then you have depression. Type 2 is the cleavage fracture plus the depression. And then type 3 is pure depression, nothing else, pure depression fracture. So you can see that it is articular involvement is there. So the rehabilitation part is very important. And then medial tibial fracture. So you have both components, medial more of medial side. You see that? And then bicondylar. So maybe the fracture in the both the components, both medial and lateral. And one more thing is the cleavage fracture. Along with that, we have the fracture is extended to shaft or diaphysis. So it is extended here also. This is the diaphasic phase. These are all epiphysis. The close to joint line, we call it epiphysis. And after that also it extends. So this is diaphysis. So the tibial plateau fractures present with tenderness. Okay. So the medial or lateral margin of the proximal tibia, you feel tenderness and swelling. Here the main problem is the knee swelling. You cannot like the controlling the swelling, and pain is severe in is so severe that we cannot progress the rehabilitation. There is a problem, swelling and hemoarthrosis. The synovial fluid gets the collection of blood, and ligament instability also. Not only the tibial condyle fracture, you have, because both ACL and PCL has attachments here, right? So this tibial condyles, the spine of the tibial condyles only, you have the primary ligaments, ACL and PCL is there. So bearing weight is really impossible for them. And X-ray changes may be subtle, so you cannot see it in the yearly version of radiographs. And because this view is mostly it is in the horizontal plane, the fracture and everything is horizontal plane, so the lateral radiograph or AP views won't give you much information. So that's why MRI or CT, so in this type of fractures, it is in the horizontal line fractures. So you need to go for MRIs because these are 3-dimensional. So you can get better orientation. And soft tissue injuries also, by the way, soft tissue injuries also can be easily visible. CT, if sometimes MRI is contraindicated, means CT is there. So diagnosis, if you talk about diagnosis, so I already told you the pain and swelling are very disturbing clinical features we have. Edema, contusion, and compartment syndrome also here, like our upper limb. In the upper limb, you have for forearm fractures, we have compartment syndrome. Here it's very common. This the compartment syndrome, we need to be alert for finding out in the first week of the fracture. You need to find out, is there any abnormalities or any loss of sensation or any pins and needle type of sensations. So the compartment syndrome should be treated. And other things are the meniscal. The menisci also commonly involved. So collateral ligament or ACL, PCL, all the important ligaments has greater chance for injuries in this type of fracture. So only CT scan and MRI can give you a better visibility. And management. So if one component, that is lateral condyle or medial, any one component is fractured and is also non-displacement, we all know we can go for this POP or conservative management. So with always have a long leg cast. Okay, so you use long leg cast and non-weight bearing. So this is also non-weight bearing for maybe you can go for 3 months. Knee immobilizer, non-weight bearing. And complications are like popliteal artery injury, DVT, and OA. These are all complications for this problem. So painkillers, the pain and edema is the primary complaint here. So the analgesics and long leg POP, long cast, and referral to follow. And then non-surgical is we already know, that is casting and bracing. And one more thing is open fractures, or we need a to clean the clean the fracture surface, because so many small segments, there is a greater chance for so many breakable pieces. So you need to cleanse the fracture surface, or else it may cause post degenerative changes. So cleaning the aspect, and then minimize the risk of infection, also very important. And that's why I told you elevation. Here the swelling is also other main problem. So elevate the limb as much as possible. Don't hang it, maybe traveling in a bus or some other vehicles, always cause severe swelling and pain. So always elevation is often important. So if it is comminuted, so many multiple fragments are there, means you can go for ORIF with bone grafting. Then only, because so many small pieces means you cannot recover it, or you cannot heal it properly. It won't that affect you. So in that cases, bone graft, because of heavy bone loss, you need to go for bone grafting. And then if soft tissue damage is severe, then we all know soft tissue injuries, you have to go for external fixation. And that I told you, the compartment syndrome should be always, you need to check. And one more thing is the normal to the quality of life after fracture is not that excellent. Okay, so because of other things like lack of full ROM, as well as loss of stability. So that's why you can expect osteoarthritis or any deformity and joint stiffness. So either POP or knee braces you can use. So weight bearing should be delayed up to 6 weeks. Okay. So it is also varies. In some cases, you need to extend more time. If signs of healing or present, means maybe weight bearing can be started. And so if there is a significant depression, the depression is involved, means you have to go for operative treatment. So if both condyles, bicondylar fractures, then no other option, you can go for 2 buttress plates and screws. So this is the buttress plates we have. In each and every circle, you can use screws. If you want more rigid one, you can use or fill all the holes with screws, or else you can left out blank also. When you say this buttress plates provide more stability compared to other types. These are external fixators. You can see that visible. These external fixators are visible, and this is cannulated screws. This is bone grafting. Fifth point is bone grafting. Okay, so this is also you may have seen this type for external wounds, for soft tissue injuries. You can go for Ilizaro fixatus. Okay. So this is for bone shortening. To correct the bone shortening, we can use this Ilizaro fixatus, which is useful for distracting or lengthening the shortened bone. You can use this one. And there's also soft tissue injuries or so severe means that is also other reason we can use this Ilizaro fixatus. Okay, the complications. We already discussed collaterals, meniscal injuries, open wounds, compartment syndrome, the popliteal artery injury, the peroneal nerve palsy, malunion, non-union, knee stiffness, post-traumatic arthritis. These are the various complications you have in this tibial plateau fractures. So let's move on to our rehabilitation for first week, day 1 to first week. The precautions are always don't ever give abduction or adduction stress on the knee, okay, and no passive range. So don't give this kind of movements, adduction or abduction of tibia, and no passive ranges. And range of motion. So range of active and active assistive flexion and extension you can start doing. Okay, that is there. And normally the 40 to 60 degrees of flexion is acceptable. Okay, so don't go beyond that. So 0 to 40 to 60 degree, and then 60 to 0 degrees. That is the only thing you can allow. And then after 1 week, you can progress to 90, up to 90, 0 to 90 and 90 to 0. So like that we can progress. And no strengthening exercises, and no weight bearing with only non-weight bearing with crutches, and for weight bearing also same thing. And second week, I told you, right? So active and active assistive for up to 90 degrees from week 2. And here also the precautions are same. No varus or valgus stress on the knee. Isometrics. From second week, you can start the isometric exercise to quadriceps. Okay, the functional activities, non-weight bearing. Okay, strictly non-weight bearing ambulation. And okay, here also same for 4 to 6 weeks also, no varus or valgus stress and no passive ranges. And here you can do a full range also. It's possible. If it is subtle and gentle, no pain means we can full range also you can go. And strength same, isometrics to quadriceps. And functional activities. So non-weight bearing, everything is non-weight bearing. After that, once again. So here also no varus up to 12 weeks, 3 months also no, don't give varus or valgus stress on the knee. And the passive movements from 8th week, you can start the passive range of motion to knee joint. And here you can start gentle PRE, gentle resistive exercises to quads and hamstrings. And then functional activities, weight bearing. You can end of 12th week, we can start weight bearing activities. You can start. And so partial to full weight bearing. Okay, so you can start with toe touch weight bearing, and then partial, or if it's easy, you can start with partial weight bearing to full weight bearing. At the end of 12th week, he should have that full weight bearing. But if it is so, we can 1 week, 1 or 2 weeks, you can increase or decrease the speed of rehabilitation. So 12th to 16th week, so the precautions, nothing, and everything is possible. And the strength also, PRE to the knee, you can start, and full weight bearing. Okay, that's it. So we will do one thing. We will end now and we will join with the other ID. Like normally for Wednesday we use, right? Please join with that ID. Okay.
Okay, Miss.